So yeah, this is the last this is the last couple of kilometers with my hip the way it was. Hopefully afterwards I'll be able to walk properly and not limping. Last few weeks I haven't been able to hide the limp. So here we go.
Apologies for the poor sound quality on these. I left the cover on the camera, so the sound wasn't coming through very well. So in this video, Michael had come around, the physiotherapist, and we're just checking to see what movement is back. So you could see there that the adductor muscles were working, so the legs are able to turn in and out. The quads are actually working as well, but there's absolutely no movement in the feet. The spinal anesthetic tends to wear off from proximally to distally, from the front of the leg to the back of the leg. So inner thighs come first, then the quadriceps, then the shins, calves, hamstrings.
Thank you very much, Michael. This is Michael. Michael's my fantastic physiotherapist and good friend. And we'll see him later on to get up.
Having a look at the obs just to see if the numbers are pretty steady and consistent, which they were. What we find is that the motor control comes back first, but the sensation takes a little while longer. Once the feet start to move, we find that about an hour to an hour and a half after they start moving, a patient could be ready to stand. Michael followed me back to the ward and was keen to try and assess whether everything was fully awake to try and stand up. So we're actually just running through all the different checks. So we're checking the foot power, so the plantar flexion, checking the dorsiflexion, pulling up. Checking the quadriceps control and straight leg raise. Checking knee and hip flexion. And then finally glute bridging on the bed. So the bed checks are just part of the assessment to see if somebody's ready to get up. Once we've assessed those and they're fine, we do a few checks in sitting. I was just pointing out with Michael here that even though the motor control is there, the sensation is still a bit fuzzy running down the legs, so there's parts of my feet were still not fully awakened, but we still felt it was just about safe enough to stand with assistance. And we're also just laughing at my poor choice of footwear. So we don't recommend this type of footwear for people up mobilizing. But that's all I had with me. Next thing is sitting balance. So try and shift your weight from side to side, leaning through left bum cheek, right bum cheek. Once somebody's able to do that, the control of the pelvis should be something similar in standing. Michael is now again checking the resisted dorsiflexion. He's just testing the sensation on the sides of the legs. abductor strength, adductor strength, quadriceps strength, right side, quadriceps strength, left side, and just a little bit of resistance as well. So here Michael's just mentioning to me the risks of standing, that the blood pressure might drop, and so if there's any dizziness, queasiness, anything that feels a bit odd, we'll turn straight around and go back. Initially to stand we used the walking frame. It's a lot steadier and I was thankful for it. The feet did feel a bit fuzzy, and actually there was a little bit of anterior, posterior pelvic control was a little bit lacking, and you'll see me kind of wobble forward a little bit now here in a second. Just right there. We kept it safe then by taking a few steps on the spot, making sure that the weight was being evenly distributed both sides before moving on. Once Michael and Jackie and myself felt we were nice and steady, decided to take a few steps. Now you generally see a huge improvement within quite a short period of time, within 15-20 minutes. A lot of that steadiness comes back as the numbness disappears. So even though this was a bit wobbly initially, it did improve quite quickly. Something key here to note is how close Michael and Jackie are staying to me. So even though they know that, from my experience working with similar patients, I should be trusted, they really should not trust me until the patient proves otherwise that they're steady. Anything can happen. So treat every patient like they could fall. So yeah, it's about 2:30. I had the surgery. The surgery was finished at about 10 o'clock this morning, so it's about 4.5 hours now after the surgery. Actually feel fantastic. The fuzziness in the legs is mostly going. It was just up with trying out the 2 crutches. So we walked about, probably in total about 40 metres. So now sitting out, I want to sit out to try and help circulation and a little bit of breathing. So while I'm sitting here, I'm going to do some foot and ankle pumps. The advantage of doing it this way is I'm moving the hip joints at the same time. That's not painful in the slightest. A little bit of adduction, abduction with some rotation. Again, not painful. And then a little bit of lower leg swing just to stop the quads from getting too tense as the swelling travels down into it. I am able to do hip flexion. I am able to extend the knee as well, but that is starting to put a bit of pressure on the hip. But usually that puts pressure on my hip anyway from before the operation. So far everything's great. I'm in lovely Kilkenny, and my surgeon, Mr. McKenna, Paul McKenna, has just turned up.
Main man.
Yeah, there he is.
Here he is.
And yeah, see how we go. Perfect.
Deadly.
Thanks. So I've been sitting out in the chair now for about an hour, feeling good, feeling great. There's a little bit of pressure around the kind of up around here, around there, but that's it so far. So it is. So yeah, I'm probably going to get back onto the bed for a little bit, just to be able to extend the legs out, allow that the swelling spreads out rather than just concentrates in the thigh. So yeah, just gonna get back into bed this time from the left side in first. There's a little bit more pressure in the hip, so I'm gonna lift my right leg in onto the left to help bring it in, and doing that completely fine. Bend the knee up to slide foot from underneath. Very comfortable. Yeah. On the bed, I can flex, assisted flex. I can do it without assisting it, but I'd rather just not make it sore if I can help it. And then a little bit of movement like that, and it's fine to do as well. You can see here that the pre-op range is quite poor, and there's really only about 10 to 15 degrees of abduction, adduction, and internal external rotation. It's fixed into external rotation actually, and fixed into abduction by about 10 degrees. In comparison to the right hip, where it has about 10 to 15 degrees adduction and 40 degrees abduction. I've placed the pillow underneath my knee, so it is in slight flexion. That way there's a little bit less of a pressure here. The dressing looks absolutely perfect. There is so far a kind of mild swelling, effusion. I haven't used any ice or anything yet. So unassisted, I'm still able to flex my hip up. Okay, I'm able to still actively adduct, abduct. Yeah, really good. Yeah, that's way better than it was even yesterday. So obviously, because of where the incision has gone, which is just here, the muscles there and there get quite a lot of a stretch during the surgery. So I'd rather kind of assist the flexion if I'm going to be doing it in this position. So yeah, it's currently about 3:45, and no pain. There is a mild discomfort, a kind of a pressure down through the front of the hip, but that's really it. And it's looking like just get prescription and everything sorted, and wait on my lift, and I'll be going home at about 6:30 this evening. So that will be 9 hours, 9.5 hours from the start of the surgery, and about 8.5 hours from the finish of the surgery, going home. So yeah, pretty good. Yeah, feeling great. Really thankful to everybody here. Everybody here is fantastic. You know, everybody's explained every step along the way. So yeah, I'm very, very thankful. Let's give it a go. So, good leg leads the way, bad leg crutches. Good leg leads the way, bad leg crutches. Good leg leads the way, bad leg crutches.
Beautiful technique.
Good leg up to heaven. And it's good leg up to heaven, it's bad leg down to hell.
Okay.
Absolutely perfect. So
Beautiful, beautiful stuff, Shane.
yes, of course it can still get sore. I understand that's possible, but at the moment I feel absolutely perfect after a hip replacement. So yeah.
Long may it continue.
Long may it continue. So yeah.
So this is Shane.
See ya.
End of day one. It's been a long day for him.
Yeah.
And he's had his operation. Now he's heading back to Waterford tonight. And Evie, the driver, has come all the way. Look at her. And the wind is blowing, and he's going to get into the car now and say.
So the seat's back as far as it goes. So there's plenty of room. Turn around, sit down first. Okay. Shuffle around. You can either bring good leg in like that and bad leg in like that.
Yeah.
Or you can bring the two together.
Yeah. There you have it, a live demonstration of a car entry with a real hip replacement.
Yeah. Yeah, look.
He has the scar to prove it. Yeah, a lovely titanium.
Or at least the dressing.
A lovely piece of titanium. Alright. And the stockings.
Sexy stockings.
Alright,
this is really why I had the hip replacement. I just really wanted to get the stockings.
Mad for the stockings. Just in time for Christmas.
I feel like Thierry Henry here with the stockings pulled up. Either that or Thierry Henry or Brittany. Yeah. One of the two. Now I'm showing my age.
Brittany. Go with Brittany.
Yeah.
Alrighty.
Anyway, thanks very much, Michael.
No matter,
thanks
man.
for all your help.